I am honored today to present the Joseph Belanti Lectureship in Allergy and Immunology. And Dr. Belanti is a professor of pediatrics and microbiology and immunology and the director for International Center for Interdisciplinary Studies of Immunology at Georgetown University Medical Center. He received his MD degree at the University of Buffalo and is very proud of his Buffalo roots as he did his residency there, and then went down to Florida for his postdoc training, and then came back up to the Walter Reed Army Institute of Research for a fellowship in viral immunology. Following his military service, he was recruited by Georgetown University School of Medicine as back then, I think he was an assistant professor, and he has continued in his time since then. Since about 1975, he has served Georgetown in numerous roles, carrying NIH-supported R01 grants, running education, and numerous projects on just incredible breadth of work. And I would point you to the 500 articles that he has published over this time and the numerous textbooks that revisions that he has done. But he is an acclaimed textbook on immunology, and I think it might be in its fourth go around, but it's clinical applications in health and disease. And so Dr. Belanti, in celebration of his illustrious career, established, along with the departments of microbiology and the departments of pediatrics, this lectureship. So this, I'm proud to announce, is the third annual Joseph A. Belanti Lectureship in allergy and immunology. And today I am proud to introduce my friend and colleague, the clinical professor Talal Nsouli, who will give grand rounds today on new insights in the optimal diagnosis and management of food allergy. This is continuing on the long legacy and tradition of Georgetown University Medical Center, as Dr. Nsouli was a fellow under Dr. Belanti, and he has continued his work as a widely acclaimed specialist in allergy and immunology. He received his medical degree with honors and residency training from the University of Brussels in Brussels, Belgium. After fellowship training here at Georgetown under the mentorship of Dr. Belanti, he was propelled internationally and nationally to more than 100 peer-reviewed papers and abstracts, and he has mentored more than 80 students and fellows interested in allergy and immunology. He serves and has served on virtually all the national advisory committees and editorial panels throughout the country in the field of allergy and immunology. Dr. Nsouli has served on those. He has received service awards from the American College of Allergy, Asthma, and Immunology, and he's a distinguished fellow of the International Center for Interdisciplinary Studies of Immunology here at GUMC. He is, on a personal note, served our department as a phenomenal educator, educating our residents and students, and frankly me and other attendings, on how to handle allergic symptoms and allergic rhinitis and food allergy in our own work. And so I want to thank him for all the work he has done for this department and the important role he plays as the director of the Watergate and Burke Allergy and Asthma Research Centers. So with no further ado, I'm going to turn it over to Dr. Nsouli to go ahead and get started. New insights in the optimal diagnosis and management of food allergy. Thank you, Talal.
Thank you very much, Mike, for your kind introduction. Let's see. One second. Trying to advance my. So first of all, I would like to certainly wish the best to Janice Thompson. Apparently, she started labor for hopefully to have a smooth and nice delivery. The slides are not going to pass. So I would like to also welcome you all by Zoom to my presentation, and I'm deeply and extremely humbled and pleased and honored to present the third Joseph A. Belanti, MD lectureship commemorating Dr. Belanti's 60 years of achievements at Georgetown. We are honoring an internationally renowned clinician, researcher, teacher, who in addition to being my mentor, counselor, and advisor for more than 40 years, is and
Recording in progress.
continues to be my friend. Before I begin my formal presentation, I would like to go back a little bit in time. Let's see. But before that, I would like to thank Dr. Richard Calderon, the chair at the Department of Microbiology, Immunology, our chairman, Dr. Mike Donnelly, chairman of the Department of Pediatrics, for initiating this lectureship. Also, I would like to thank Dean Ray Mitchell, the best dean in the United States. He was very nice. As soon as he knew that I was selected to give this lectureship, he sent me an email congratulating me on that. Thank you all very much. So early in time, Dr. Belanti did his initial training at the University of Buffalo under the mentorship of Dr. Calcagno. And we see Dr. Calcagno in here carrying his, holding his very elegant pipe. Dr. Belanti is here. And then later on, he went to the Department of Pediatrics, University of Florida, where he did a postdoctoral program in immunology. We see Dr. Belanti in here is getting even taller, to be honest with you. And Dr. John Robbins, very famous on his right side, who discovered the hip conjugated vaccine. In 1963, this is when Dr. Belanti came to Georgetown. Dr. Philip Calcagno was the chairman, and he appointed Dr. Belanti as a full assistant professor at the Department of Pediatrics at Georgetown. And Dr. Calcagno was the founder of the Department of Pediatrics, the academic Department of Pediatrics, starting in 1962 to 1988. As you see on the slide, Dr. Belanti is here now. He's much more credibility with all the science that he has. But before that, Dr. Belanti was at the Walter Reed Research Institute. While he was at the Walter Reed Army Institute, he did a lot of research, and he made the seminal discovery of mucosal IgA in respiratory secretions and its importance in antiviral immunity. He always believed in the mucosal immunity, and very important. He directed research to vaccine delivery via the nasal route, a technique that provides better protection by stimulating mucosal IgA than by IgG in serum. Dr. Belanti and his colleagues were the first to describe the sequential appearance of IgM to IgG in serum in young infants and in adults following infection and immunization. Breakthrough discovery. At Georgetown, Dr. Belanti and his colleagues were the first to isolate the rubella virus from several tissues in an infant who died from congenital rubella, unfortunately. This was a significant discovery because it provided further evidence that rubella could be transmitted from pregnant women to her unborn child, causing CRS. The IgM assay is now widely used diagnostic tool for a rubella, a forerunner of the torch assay used internationally, used by neonatologists for the diagnosis of other intrauterine infections. And we see in this nice immunoelectrophoresis slide, the upper part of the slide in here, we see the serum from the immunoelectrophoresis from a healthy mother and the serum from the healthy baby. We see the IgG arcs shown in here. In contrast, on the bottom one, we see sera from a mother who had the rubella and that gave birth at a 1 day old infant with congenital rubella. We see the IgM arcs in here, prominent arcs that we see it at this level. Again, a major breakthrough in the field of medicine. Many accomplishments with Dr. Belanti, but I think one of the most important one was the 4th edition of his widely acclaimed textbook in immunology, the Immunology 4, clinical application in health and disease. So this is an encyclopedia of immunology looking at the academic portion and the clinical portion, unbelievable book. Dr. Belanti has been involved in teaching immunology to medical students, residents, and graduate and postgraduate program students as well, directing the postgraduate training program in developmental immunology. Dr. Belanti directed the clinical residency program in allergy immunology from 1978 to 1992 and trained more than 300 postdoctoral fellows. I was very lucky to be one of them. Joseph Belanti has continued to pursue his scholarly pursuit over the past 60 years, actively involved in teaching and research and collaborative studies with basic science colleagues. He has held numerous leadership positions and has published more than 400 papers, scientific papers, very advanced ones, including, including his famous textbook in Immunology 4. His current focus is directed to studies of epigenetics, mechanism of DNA methylation in control of gene expression related to Treg function in control of allergic and autoimmune diseases. So this one day we're at the annual meeting, I think in Arizona. After a board meeting, as you see on the right side, we had a little breakfast together in here. And when we sat down on the table waiting for the coffee and waiting for the fruits to arrive, Dr. Belanti grabbed a napkin and he told me, Talal, let me show you the secret of scientific contribution to medicine. And he showed me, this is his own handwriting. Belief, faith refers to religion. Magic refers to imagination. Medicine refers to research. But most importantly, he always said, most important is evidence-based medicine. And he always brings this to the table, that there is no substitute for clear thinking. Of course, medicine is an art, in my personal opinion. Often in medicine, 1 + 1 = 2, but sometimes 1 + 1 = 8. And this is the reason that we have a license to practice the healing art and will never be replaced by computers. Now, of course, some of the activities of Dr. Belanti, on the left side, we see when he was elected the president of American College of Allergy as Immunology. In the middle, he's with his fellows. This is my brother Safa, who was also trained by Dr. Belanti, allergist in California. Dr. Zebedi, allergist trained by Belanti, but he's now in Panama. And this was during the annual meeting. Dr. B is also evaluating the different studies that are presented and analyzing them very clearly. Dr. Belanti with Dr. Phil Calcagno in here. They are in Las Vegas. It looks like Las Vegas. This is me and Dr. Belanti attending a presentation. Notice I'm falling asleep and Dr. Belanti is still wide awake. And we see in here Dr. Belanti having dinner at the White House. And I'm not going to get involved with politics today. Dr. B had numerous awards, hundreds of awards. One of them that's, I think, very important is the Gold-Headed Cane Award by the American College of Allergy as Immunology. They select one allergist per year, one expert per year, to recognize a physician who symbolized the pursuit of the highest standard of scientific excellence and integrity. Congratulations, Dr. Belanti. But I could be talking for 3 days about his award and achievements. Also, Dr. Belanti is a musician. I mean, he is in love with piano. He's an excellent pianist. And whenever you see a piano, he's playing on it. His favorite music is New York by Frank Sinatra. We see Dr. Belanti very elegant in here. Remember, his genes originally came from Sicily, Italy. Very handsome. And it is at the American College of Allergy presenting his books with his handsome son, Tony. Dr. Belanti likes to eat some nice food in Italian and French restaurant, giving lectures all the time. And in addition to that, you cannot walk with Dr. Belanti because every time you walk, someone is going to come and interrupt him, ask him questions. He's always surrounded by fellows, attending physicians at the meeting, asking him scientific questions, and this is very exciting. This is a paper by the American Psychological Association. You might wonder what this has to do with this. And they showed clearly that after a certain age, we have a decline in cognitive function, reasoning, speed, memory, vocabulary. With the age, this go down. But let me tell you, with Dr. Belanti, there is something different that happened. Dr. Belanti, all these different functions went up with the age. Dr. Belanti defies brain physiology. Why? Because use it or lose it. He, like a muscle, he has been using his brain all the time, doing studies, research, presentations, and this keeps him very active at that time. But also there is something else going on, is the fact that he has a wonderful wife. Her name is Jackie. There is always a woman behind a successful man. Also, he has a wonderful family, as you see in here, and great genes coming from Sicily. And he drives a beautiful car. The license plates say Amore, love. So science, family, and love keeps him all the time very successful, in good shape. So since I was trained by him, I tried to follow in Dr. Belanti's footsteps. I know it's very difficult, but I thank him for everything he taught me and everything he gave me as scientific information. And now I'm going to go to my official lecture. In here, a new site in the optimal diagnosis and management of food allergy. It's an extremely large one. I hope that you all had enough coffee, because I'm going to be covering a significant number of data in here. So we know that food allergy is still a serious health problem today, since 32 million have food allergy. 4 to 6% of them have food allergy in the pediatric population, and affecting the quality of life of the child, but affecting the quality of life of the family surrounding the child. Usually, egg, milk, and peanut represent 80% of food allergy in the pediatric population. Another important, unbelievable number, between 2007 and 2016, we have 380% increase in anaphylactic reaction due to food allergy. Unbelievable. And this results in, unfortunately, major costs in the United States. Food allergy costs about $25 billion a year due to food allergy in the United States. So food allergy can present in my clinic and in your clinic in a variety of scenarios. Food reaction, food allergy, food intolerance. So let's review a couple of them. 10 months old, vomits repeatedly 2 hours after ingesting rice cereal. What's your diagnosis? Any idea? Food protein enterocolitis syndrome. 17-year-old gets bloating and diarrhea after eating pizza and ice cream. Diagnosis, lactose intolerance. A 12-year-old develops anaphylactic reaction after ingesting a trail bar. Easy diagnosis, tree nut allergy. 4 family members went to a nice restaurant and they ate a tuna dish that was very delicious, and all of them developed urticaria, flushing, etc. Your diagnosis, choroid reaction. This is a 3-year-old with atopic dermatitis, has eczematous flare after eating eggs. Diagnosis, egg-induced eczema. 19-year-old seen at the emergency room after a steak that got stuck going down to the throat. What is your diagnosis? Dysphagia caused by eosinophilic esophagitis. A 21-year-old hunter developed an anaphylactic reaction 4 hours after eating steak. Your diagnosis, any idea? Of course, alpha-gal hypersensitivity. 16-year-old gets a runny nose after eating any food. Runny nose all the time, gustatory rhinitis. To give you a taste of the variety of scenarios that one can deal with. This is my outline. I'm not going to read it of interest of time. I'm going to go through it one by one. The physiology, pathophysiology of food allergy. So we know that we do have adverse reactions that are not hypersensitivity reaction, bacterial food poisonings, choroid food, fish poisoning. And we have the non-allergic or intolerance, lactase enzyme deficiency, delayed maturation of fructase enzyme, and galactosemia. Then we have immune-mediated, IgE-mediated anaphylactic reaction and urticaria, non-IgE-mediated isolated gastrointestinal reaction, skin rashes, and in between atopic dermatitis. I think it's 30 to 40% due to IgE, but could be non-IgE. EOE also partially could be IgE-mediated, but also is non-IgE-mediated. What about the epidemiology? So what are the common foods in adults? Peanut, tree nut, seafood, veggies, and fruits. We have to add to them the newly arrived allergen that comes in an official and legal list, the sesame. I will come back to that. The common food allergen in children: egg, milk, soy, wheat, peanut, tree nuts, and seafood. And now we have to add the sesame as of 2-3 weeks ago. What are the different representation due to food allergy, anaphylactic reaction, acute urticaria, atopic dermatitis, and syndrome of gastrointestinal allergy as well. Don't forget the studies that were conducted a while ago showing the role of food allergy in serious otitis media. So if you have a patient who's having serious otitis media all the time, do not run right away for the tympanostomy tube. Look at food allergy, avoid the food allergen, and evaluate, and you will see in the majority of cases their serious otitis media will resolve. Atopic dermatitis as well, often people are not taking consideration that food allergy can cause that. We did a study a while ago, and newer studies confirm that. In this patient, we do have also Staph aureus that has to be addressed immediately. President Biden signed a law that makes sesame the 9th major food allergen. Why? A lot of people have been having sesame anaphylactic reaction to sesame. So now, to comply with the new sesame allergy law, some businesses are adding sesame. Unbelievable story. Why? Because it's cheaper to add some sesame to the food than to avoid cross-contamination when this came out. And this is of concern now because we are worrying we're going to have more foods that contain sesame in the United States because of this financial decision from the food industry that is less expensive to add some sesame than to completely isolate the sesame from the food. And believe it or not, they added even sesame to the white hamburger bun. 2% of sesame was added. Like that, they don't have to worry about saying there is sesame or no sesame, and this could be problematic. But it is the official one that was added in here recently, January 1st, 2023. We have 9 allergens. This is a very important plate that some of allergists are very familiar with it. Cross-reactivity in here within the food group and cross-reactivity with the pollen. For example, if you're allergic to legume, we have 5% chances to be allergic to other legume. If you're allergic to shellfish, we have 75% chances to be allergic to other shellfish. Allergic to cow's milk, we could have 5% or 10% chances to be allergic to beef. And also, I would like to let you know that if you're allergic to latex, we could be also allergic to kiwi, banana, and also avocado. Keep it in mind. Pertinent and careful clinical history. Very, 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 very important. The pertinent history is very important. So we're going to ask mom or dad and the family the timing. Johnny ate the food, how long it took for the reaction to occur. Number 1. Number 2, what are the symptoms? Did you get a little scratchy nose? Did we sneeze twice? Whether objective or subjective symptoms, okay? We like to see the objective symptoms, rash, urticaria, etc. What about the quantity of the food? How the food was cooked? Treatment or resolution? Did Johnny had a little bit of itching and little rash, and without any treatment everything resolved? Or that Johnny had to receive 3 injections of epinephrine in order to resolve the generalized rash? Cofactors with exercise, medication, NSAID, and others. So that the history informs testing, and testing helps to confirm suspected allergen based on the history. Very important. After all, guys, we are clinicians and we are not computer specialists. Look at this 7-year-old white female who was referred to our clinic, labeled chronic idiopathic urticaria. We do not know what's causing that. She was put on hydroxyzine on daily basis, twice a day, making her sleepy and drowsy. She had a good evaluation by primary care, CBC, differential citrate metabolic panel, normal skin testing to foods, immunocap IG to food negative, no food allergy. The ANA was negative as well. So they told her there is nothing to do. She came to see us. We took a careful history. She has a dog. She likes to go for a walk in the garden with the dog 2-3 times a day. And she was exposed to a tick bite. We did the alpha-gal. The alpha-gal came back to be positive. Once it's positive and we have some hives, highly likely we have red meat allergy. Avoiding red meat, everything resolved. We stopped the hydroxyzine and she's doing well. Selecting the right test for food allergy. We know that we have 2 important testing. We have the allergy skin testing, prick skin testing, and we do have the food-specific IgE. Avoid ordering big panels to avoid overdiagnosing. If we are sensitized, we have a positive test, doesn't mean that we are always allergic. We need to have some clinical correlation. Larger wheel on the skin prick testing and higher values can be significant, that correlate with higher likelihood of reactivity, but not severity reaction. Negative results, they correlate with highly likely patient is not allergic. Keep it in mind. Now the different component testing, and this is something very important. So we do have a variety of proteins in the different food allergens, but some proteins are important, the storage proteins, and you see the risk increases from the left to the right in here. So the storage proteins that are known to be allergenic, usually with the peanut, are 1, 2, 3, and 6, hazelnut, core A, 9, and 14, walnut, jerk 1, the Brazil nut, bear E1, and we do have the cashew ANA03. These are important to be aware about it if the patient has antibodies specific against these storage proteins, high risk. The one that was added recently is for sesame, is the component for the SESI1, and for wheat is TRIA19 and TRIA14. These are important to know about them. So the diagnostic cutoff for the predicted positive value in terms of testing, skin testing, and the immunocap. This is a very important slide in here. Look at the cow's milk. If we have more than 15 kilo unit on the specific IgE, we have for the milk, highly likely we have 95% chances positive predictive value. If we look at the skin testing for milk, if we have a wheal that's more than 8 millimeter in size, highly likely allergic to the milk. If less than 2 years of age, 6 millimeter and above as well. And to show you that every food has different values as well. Let's refine it a little bit more and go to the food allergy testing component. We can look at the component as well. So let's say the component for peanut ARA2, the cutoff could be 0.32 to 42 kilo unit per liter of the IgE. It means you have 95% chances that the patient is allergic. In order to an oral food challenge, it has to be, we do it safely, possibly if the patient has less than 1 kilo unit per liter. These numbers are provided by Dr. Hugh Sampson, who is the biggest expert in the United States and worldwide in terms of food allergy. These are the numbers that he uses to do oral food challenges without taking a great deal of risk. Algorithm for food allergy and diagnosis. So initially, detailed history, non-IgE mediated. We're dealing with history of FACAAIs, or we do have the food protein induced proctocolitis. We do have EOE, or we do have also the eosinophil gastrointestinal disorder, food avoidance, or oral food challenges. If we have IgE mediated, the skin prick testing could be negative. Then with poor history, we introduce the food. Negative skin testing with the possible positive history, we do a specific IgE, and then, sorry for that, we do a specific IgE testing, and then if the IgE specific is less than 0.35 kilo unit per liter, no problem, introduce the food. If it is above 0.35 kilo unit per liter, but less than 40% of the positive predictive value for the specific food, oral food challenge. If it is above 50% of the positive predictive value, avoid the food. Again, we have to be very careful with this diagnosis. So now we go to the oral food challenges. We know that 80% of food allergies can be diagnosed with the algorithm outlined above. However, oral food challenges remain necessary and accurate in some cases. But if you're going to be doing it, we have to be careful. Number one, we have to know the risk-benefit, because it could be triggering an anaphylactic reaction. And parents have to sign some documents being aware about the risk involved with that. Consent form. Stop antihistamine. Emergency medication should be available. IM epinephrine, H1 antihistamine, albuterol, and also other supplemental oxygen and IV fluid as well. The oral food challenge, normally the best one is double-blind placebo control oral food challenge, gold standard for research only. In clinical practice, we use open oral food challenge, mostly in the clinic. So usually it's done with a certain appropriate size depending about the age. And we do have two protocols for the oral food challenge. Protocol 1, 4-dose protocol. Protocol 2, 6-dose protocol. And in between these doses, we leave 15 to 30 minutes in between. And then as soon as we get some reaction, we stop the oral food challenge. What are the emerging new food testing, food allergy testing that could be available? The epitope mapping and the basophil activation test. Let's look at them. So why are we interested in looking at more new testing? In order to hopefully limit the need for the oral food challenges that could be risky in some cases. So the epitope mapping, as we know, peanut has 64 binding sites, are 2 dominant peanut allergen. To identify the amino acid sequences that are bound to the IgE and can cause these allergic reaction. Epitope accuracy, epitope testing accuracy, 93 accuracy for the diagnosis of peanut allergy. Extremely important, 93. We have the basophil activation test, the BAT. Usually uses a flow cytometry. We need to have the blood to be fresh within 24 hours. So this is a little bit a bottleneck. And to do the testing, 90% accuracy as well. And they are not yet in the commercial lab, but they are used in some labs. Hopefully they will be out in commercial labs as well. Dr. Hugh Sampson is also one of the big pioneers in terms of oral immunotherapy. And we notice in here, in testing for food allergy, we notice in here that the latest test is certainly the epitope testing, the bead-based epitope assay. Look at the beads. They have the beads in here. They put particle of the peanut and they mix it with the serum of the patient, and they see if the patient has IgE specific to these specific epitopes that can cause anaphylactic reaction, and will be able to know clearly. So studies published October 2022 showed clearly that the bead epitope testing was 93% in concordance to an oral food challenge result, and hopefully we'll be using it more and more. The basophil activation test, some of you are familiar with it, is very simple. Instead of challenging orally with the food the child and waiting to see the child anaphylaxing, we will challenge his or her basophils and to see if the basophils are going to be anaphylaxing or releasing cytokines and chemokines, doing it in vitro. And this hopefully will prevent from unnecessary food challenges. Very interesting test, and this is a new study that was published on it as well. So the treatment of food allergy, as you will know, avoiding the food if the food is extremely aggressive, or immunotherapy. So we do have the oral immunotherapy, sublingual immunotherapy, and some future therapies that I want to discuss with you. But since we are talking about food and anaphylactic reaction, I would like to mention something about that in here. It's important to know, and you all know that, I'm not showing you anything new, but I would like only to refresh your memory. In advanced anaphylaxis, epinephrine will not reverse the reaction. Why and how? Look at this in here. This is the degree of success with the epinephrine, and accordingly to the time. Longer we wait, less effective will be the treatment due to the vasodilation phenomenon. So this is the blood vessel in yellow. The blood vessel reach the green zone when we can still do some vasoconstriction, but when you get to an irreversible vasodilation, irreversible hypotension, and then the patient dies, and that's very important. What does it mean? We have a window of opportunity. That's why I put the window in time to give the epinephrine and not to delay it. If we physicians, we question ourselves, should I give the epi to this patient or not? The answer is yes. If you question yourself, go ahead and do it, for especially for our residents. This is an important tip in here, to avoid an irreversible condition that can lead to death at that time. The other question, the self-injected epinephrine. Are people using correctly their self-injected life-saving epinephrine? What do you think? Yes or no? The study that we conducted with our colleagues showed a disaster. It showed that 70% of people that have a self-injected epinephrine, they will tell you, I know how to use it, we'll give it to them, they don't know how to use it. So we concluded that we have to teach them every time they come. We ask them to demonstrate it, and you will notice that people very quickly forget how to use correctly the self-injected epinephrine. Now also you're going to tell me we can prescribe them this type of auto self-injected epinephrine that talks to you. So this machine, I love it because it talks to you. But when people are panicking, they panic. And we notice that we gave it to them, we tell them, show me how to use this self-injected epinephrine that talks to you, but they did not know how to open it. So we have also to show them that, and the price is a little bit on the high side. Now also, hopefully in the soon future, we'll be having intranasal epinephrine. This is the Neffy spray that we only spray it in the nose instead of injecting it. Will make it much more easier and very practical, but still pending with the FDA. In 2020, January 31st, it was an approval for oral immunotherapy treatment for desensitization called Palforzia, which is peanut powder to desensitize our patients 4 and above 40 years of age. So outside the peanut, outside the food, the FDA approval studies for the peanut, all other oral immunotherapy are being done with products purchased in the grocery store. So only the peanut came standardized. The other ones are purchased at the grocery store. Most extensive data on peanut, egg, and milk, still exploring the difference in ages, products, protocols, goals, etc. Other foods are more limited in data: wheat, tree nuts, fish, shrimp, and most importantly, multi-food. What are the expectations from the treatment? What are we expecting? Reducing the risk from an accidental exposure? I think yes. Ability to introduce the food into the diet? Maybe yes, maybe no. Long-term success in this really lifelong treatment? Question mark. Goals and expectation and long-term outcome, again, things have to be evaluated. Dr. Robert Wood, he's the father and the biggest expert in oral immunotherapy. So I would like to mention in here about a couple of definitions. We have desensitization with oral immunotherapy, which is raising the food threshold that causes reaction, protect while on therapy. Tolerance or sustained and responsiveness. I like to call it TSU, long-term modification of the immune system from Th2 to Th1 and increase the T regulatory cells that will result in sustained and responsiveness. How it is done? How do we do the oral immunotherapy? So we start with very small doses, 5 doses, 30 minutes apart. Then we have 11 doses going up incrementally, about 24 weeks. And then we maintain 30 milligrams daily on regular basis in order to keep the treatment ongoing. What about the sublingual immunotherapy? Similar to that, but we have a more rapid build-up and much lower doses with the sublingual versus the oral immunotherapy for foods. So this is an important slide. More than 50 studies were reviewed by Dr. Robert Wood. Majority of patients can be successfully desensitized. The degree of desensitization will depend on the maintenance dose used, range from milligram to grams of food proteins, potentially sufficient to introduce the food into the diet. The desensitization is transient in most patients without ongoing exposure. It is possible that tolerance or sustained responsiveness is more common, number 1, in younger individual, number 2, less allergic individual, number 3, in higher maintenance dose, and number 4, co-administration of the anti-IgE omalizumab that you all know we use it for a variety of other conditions. So what are the different information that we need to know about oral immunotherapy? The severity and number of reactions appear similar to milk, egg, and peanut and wheat. What does it mean? It means peanut, we thought, is very aggressive. It's not more aggressive than egg, milk, and wheat, according to this recent studies. Reaction rates are extremely high, affecting virtually all patients, but most reactions are mild. Moderate reaction occur less than 10% of doses. Severe reaction or reaction treated with epinephrine, less than 1% of doses. But since so many doses are needed per the patient, significant reactions are very common. For peanut, moderate to severe reaction are at least twice as common and more likely 10 times more common than would expect with strict avoidance. Look at this. Reaction may not decrease and certainly do not disappear during the treatment. Over time, gastrointestinal symptoms are the most common reasons to discontinue immunotherapy. Johnny says every time I'm getting this maintenance dose, I'm having some GI pain, abdominal cramping, in about 25% of patients, and we have patients that do develop EOE in 5% of these patients. Is the risk of oral immunotherapy worth taking? Question mark. Maybe for some foods, but not the others. The answer to these questions depend on the long-term outcome, 24 to 48 months. Studies are limited and with mixed results. This is a study published in the New England Journal of Medicine on oral immunotherapy for egg, randomized placebo control. Let me go to the results very quickly in order not to bother you with too many numbers. 75% were desensitized after 22 months of oral immunotherapy with egg. 19 out of 30 who were desensitized at 22 months lost at least some protection after avoiding the egg for 8 weeks. And that's important to know. We need to keep on eating the food. Long-term treatment of egg for oral immunotherapy enhanced sustain and responsiveness that persists after cessation. So these patients that we saw in the previous study were injected in this study by Jones et al., published in the JACI, and showed that in 32 subjects still dosing at 3 to 4 years, 54% still reported reaction with dosing, anaphylactic reaction occurred. So the risk is still there. What about cow's milk immunotherapy? So we know, although most participants in these the two studies trial had very positive outcome, 3 to 5 years later, 25% of patients consumed milk without symptoms, only 25%. So again, due to the fact that these patients, they discontinued the daily maintenance treatment due to gastrointestinal symptoms and possible anaphylactic reactions. This is the POISE study on sustained treatment, especially with the peanut, a large randomized double-blind placebo-controlled study. I'm not going to bother you with the numbers. I'm going to go right away to the results. At 156 weeks, 2/3 of the patient lost their protection, and that's important to keep it in mind. Now, the safety of peanut oral immunotherapy between 1 and 3 years of age. In here, the conclusion of the study: initiation of peanut oral immunotherapy before the age of 4 was associated with an increase in both desensitization and remission. What does it mean? The earlier we start, the better results that we get. This is a future treatment of oral immunotherapy, which is the skin patch ring. The Viaskin is a ring that you apply on the skin on the back that contains some particles of the peanut. The particles of peanut, they migrate through the epidermis. They go to the Langerhans cells that they connect right away with the T regulatory cells, going from the Th2 allergic pathway to the Th1 non-allergic pathway. The study that appeared very recently showed clearly by Hugh Samsom et al. That more than a 4-fold increase in the number of patients that were able to eat the food, and there were 4-fold increase in the quantity of the food that the patients peanut were able to eat, but still under investigation. What about adding omalizumab to oral immunotherapy? Yes, it was helpful. Not helpful in terms of efficacy, but omalizumab in combination with food oral immunotherapy led to a significant improvement in safety, but not outcome. So it gave us a safety, not to anaphylaxis during the oral immunotherapy. What about the patient asking you, is Johnny is going to outgrow his allergies? So what are the food allergies that you can outgrow? Milk, egg, wheat, and soy. What are the food allergens that highly unlikely that will outgrow? You know them: peanut, tree nuts, fish, and shellfish. What are the potential future immunotherapies that are available? A variety of them that are under investigation: the hypoallergenic peptides, the dupilumab, anti-IL-4, anti-IL-13, omalizumab, the plasmid DNA, and others, to tell you that more studies are done on a regular basis. The prevention of food allergy. I don't like to use the word prevention because prevention means we'll stop something from happening. We cannot stop anything from happening, as you will know. Decreasing the incidence, trying to reduce the occurrence of an event. This is how I see it. Again, our friend Dr. Gideon Locke from the Royal College from the United Kingdom and a very nice individual that changed the life of food allergy, to be honest with you, not only in the UK, not only in Europe, not only in the United States, but around the globe. One study changed the whole policy. That's fine with me. Okay, so, but in here, we're talking about using early in life the moisturizers. So they concluded in their study, findings support that the notion of regular application of moisturizers to the skin in young infant promote the development of food allergy through transcutaneous sensitization. We're putting now the moisturizer and we're causing food allergy. Well, how this is occurring? So there are maybe reasons, possibly due to the fact that the parents are not cleaning their hands very well from the egg or from the peanut or whatever they are eating, and then they are applying on the skin of the patient, and this could be causing the sensitization phenomenon. So number one. Number two, we know that some moisturizers do contain food, okay? And they are called hypoallergenic. Look at this one. Hypoallergenic moisturizer that contains avocado, that contains sunflower oil, that contains shea berry, that contains coconut oil, that contains oat, that contains almond oil. Unbelievable. We are applying on the skin, and this can possibly sensitize the baby at that time. So through the skin damage, slowly, some foods can penetrate and can activate at that time the TSLP, the stromal lymphopoietin. TSLP is an alarmin that very recently discovered that plays an important role in the domain of allergy. It is produced by the epithelial cells, and automatically, once it's released, activates the Th2 pathway, cause allergic reaction and also possibly food allergy. This is another study in here on the skin barrier, the importance of the TSLP and the atopic march, and what they showed in here that food going through disrupted skin barrier can cause sensitization and food allergy. Okay. However, therefore, improving the skin barrier presents an interesting barrier to preventing food allergy. So if we are using the appropriate moisturizer, we can prevent it. In a study published by Winslow et al., you will see it in here. So 3 elements to remember in terms of, again, not preventing, but reducing the incidence of food allergy. Number 1, using the appropriate moisturizer, not the one that has foods, okay? Using the one that is a trilipid moisturizers, okay, that contains ceramides on a regular basis. Number 2, decreasing staph aureus on the skin. Very important. And number 3, if the patient has atopic dermatitis, use of corticosteroids, PDE4 inhibitors, calcineurin inhibitors, collectively will decrease the incidence of food allergy. During breastfeeding, we don't have to avoid any food unless the baby is sensitive to the food, and every time mom eating eggs, the baby's having some rashes, we tell mom not to eat the food. But right now, there is no restriction during pregnancy as well. Mom can eat whatever she wants. Coming back to my friend, Dr. Gideon Lack in here, on the LEAP study that you know it very well. I don't want to spend too much time. But the conclusion of this unbelievable study that changed the life of everyone around the globe, early introduction of peanut significantly decreased the frequency of the development of peanut allergy in high-risk individuals. So again, starting to give peanut extracts early, 4 to 6 months of age, maybe more 4, that's why I put in here. They're talking about 3 now, but 4 will be good to start to introduce him. In their study, they introduce him with the form of bamba. You see the bambas in here, but could be introduced in some diluted forms of peanut powder. Decrease it in that regard. But we have to be careful. This is another study that came out recently. Dr. Belanti brought it to my attention. Appeared yesterday, May 2023, by Dr. Burke, who is also a big expert in food allergy. Please push the peanut. The title of that. We need to make sure that children with severe eczema have peanut introduced close to 4 months of age, not 6, 4 months of age. However, I go also with the NIH guidelines and the guidelines that we see in clinical practice. If we have an egg allergy, see an allergist to check for peanut allergy before giving the peanut at that time. We have to keep it in mind. So important right now, all kids have to start to eat, to have peanut exposure by mouth, of course, at the age of 4, more so 4 than 6, to hopefully decrease the incidence of peanut allergy that can occur later, especially with eczema and others. So this is the LEAP-ON study, effect on avoidance of peanut allergy after early administration of peanut. So what they did in here, the patient started to have peanut early in life at month of 4 or 6 months of age, and then later on they stopped for 12 months. They didn't eat any peanut, and they reintroduced peanut, and guess what? Nothing happened. They did not have any allergic reaction. And this means that by doing this method, we will have a sustained and responsiveness, good protection against peanut allergy. What about probiotic Chinese products and others, the Chinese herbs? Randomized placebo-controlled studies in here. So they added they added in here the probiotics to oral immunotherapy, and they compared it without any probiotic, and they noticed that there is no difference when we add the probiotics with oral immunotherapy. No significant difference. The other one are these Chinese herbal formula that have been waiting to see their formula called the FAH2. They did a nice study published in the JACI and showed there is no significant improvement. They demonstrated failure in terms of food allergy. What about the allergy toothpaste for immunotherapy? This is very interesting. So this is the toothpaste. They put in it some food allergens, and we are brushing our teeth. It goes to the oral mucosa, and by doing that, it's easier accepted by the family and by your children, and it's used on a regular basis, and apparently it gives a good result. Still in the investigation phase 1B, the study is still ongoing. So the summary and practice takeaway. This is a summary, okay? Number 1, a careful clinical history is crucial for guiding the diagnostic workup and for reaching a correct diagnosis. Number 2, no laboratory test by itself will diagnose food allergy. Number 3, while the oral food challenge is still the gold standard for diagnosing of food allergy, most cases can be diagnosed with a detailed medical history and appropriate lab testing. Number 4, the outcome of oral immunotherapy and SLIT seems to be more desensitization rather than tolerance. Number 5, oral immunotherapy is not for everyone, and any potential benefit, risk, or gain must be carefully weighed against the known risk of this type of treatment. The word cure should not be used in any discussion of oral immunotherapy, and Dr. Bob agreed with me. Number 7, protocols are being developed to arrive at regimens higher safety and efficacy with long-term, sustained, and responsiveness. Thank you very much. I would like to thank also my team that worked with me, Dr. Eliana Abu-Jaudi. She's a fantastic allergist immunologist, assistant professor also in our Department of Pediatrics at Georgetown. My nurse practitioner, Dr. Nadine Di Liberto, Soad Nsouli, my daughter, Kristen Davis, all of them providing excellent allergy clinical care and also involved in the research that we are doing. We're coming back now to Sicily. Beautiful picture in here. For me to thank you so much for being patient, because I gave you a lot of information. And also, congratulations to Dr. Joseph Alfonso Bellanti on all his outstanding achievements for more than 60 years. Thank you very much. And this is the end.